All right, everyone, settle in. Welcome to what I promise will be a very high-yield board review on acute inflammation. Look, for the next few minutes, we're going to break down one of the most fundamental processes in all of pathology. And I don't want you to just memorize facts. I want you to understand the strategy, the players, and the outcomes. Okay, let's dive right in. So, to really get a handle on this topic, I want you to think of acute inflammation as a battlefield. It's the perfect analogy. A foreign invader, a pathogen, a splinter, you name it, has breached the gates. And in response, the body basically declares war. The first responders, the army of our innate immune system, our leukocytes, they get mobilized to contain and crush this threat. This whole battlefield idea is going to be our guide through this entire process. And here's our battle plan. We'll start by defining the battlefield itself. Then, we'll cover how we actually mobilize the troops. That's the vascular response, and how we get them into the fight through leukocyte extravasation. After that, we'll see exactly how they neutralize the enemy, and we'll wrap it all up by looking at the command and control signals. Those are the chemical mediators, and finally, the 4 possible outcomes of this entire conflict. So, first things first, let's define our terms. What exactly are we talking about when we say acute inflammation? This right here, this is your money definition. It's immediate, it's innate, and the 2 key players you have to associate with it are edema, that's the fluid, and neutrophils, our frontline soldiers. And what kicks it all off? Infection or tissue death. That's it. The goal is simple: eliminate the pathogen and clean up the debris. Okay, so before our army can even fight, we have to get them to the front lines. And that means we need to control the supply lines, the blood vessels. This whole phase is the vascular response. And it happens in a really precise sequence. First, there's the super brief transient vasoconstriction, but that's almost immediately followed by a persistent vasodilation. This increased blood flow is what causes 2 of the cardinal signs of inflammation you'll see in your patients: rubor, which is redness, and calor, or warmth. Then, with the floodgates open, fluid starts to leak out, and eventually the blood flow slows way down to a crawl, a state we call stasis. Now, this is crucial. The single most important step in this whole vascular phase is this jump in vascular permeability. Histamine comes in and causes the endothelial cells lining the vessels to actually contract, creating these little gaps. And through those gaps, this protein-rich fluid called exudate floods into the tissue. And that causes the 3rd cardinal sign, tumor or swelling. The battlefield is now officially prepped. All right, so blood flow has slowed down, the vessel walls are leaky. Now it's time for the cellular phase. We've got to get our neutrophils, our boots on the ground, out of the blood vessel and into the tissue where the fight is actually happening. This whole process is called leukocyte extravasation. Now, listen up, because this is a classic, high-yield 5-step process that you absolutely must know cold. Thanks to stasis, those heavy neutrophils fall out of the central blood flow and just kind of move to the edge. That's margination. Then they start to tumble and roll along the vessel wall. Then they stick firmly in a process we call adhesion. Then they squeeze through the wall via transmigration. And finally, they follow a chemical breadcrumb trail to the enemy, which is chemotaxis. So let's drill this. Pencils down. Pop quiz time.
First question, rapid fire. To slow that speeding neutrophil down, the endothelium puts up speed bumps. So what are the molecules involved in this rolling step? Just take a second. Think about it.
That's right, selectins. Specifically, you've got P-selectin, which is released super fast from Weibel-Palade bodies, and E-selectin, which is induced by TNF and IL-1. These selectins on the endothelium grab onto a molecule called Sialy-Lewis X on the neutrophil, and that's what causes it to slow down and roll. Perfect. Okay, next question. Rolling isn't enough. We need that neutrophil to come to a dead stop. So what molecules are responsible for this firm adhesion? Lock in your answer? Excellent. It's the integrins on the leukocyte binding tightly to cellular adhesion molecules, or CAMs, on the endothelium. And you know, what's really high yield to remember here is that inflammatory mediators like C5a and LTB4 are what actually activate these integrins. They're basically shouting at the neutrophil, okay, stop, this is a place. All right, last one, and this is a huge board pearl. The neutrophil is stuck to the wall. Now it has to actually squeeze through. What is the key molecule that mediates this transmigration step? This one is critical. What do you have?
PECAM1, also known as CD31. You have to know this one. It's on both the leukocyte and the endothelial cell, and it basically acts like a zipper, guiding the cell right through that gap. Fantastic work.
Okay, so our neutrophil is now in the tissue. It has arrived at the site of invasion. Its mission is simple: find, consume, and destroy the enemy. This is phagocytosis and killing. Now, the neutrophil is pretty good at finding pathogens on its own, but the process is made way more efficient by something called opsonization. I want you to think of it like painting a giant target on the enemy's back. Molecules like the antibody IgG and the complement protein C3b act as opsonins. They just coat a microbe and make it so much easier for the neutrophil to recognize and eat it. And this is just brilliant. This is how the neutrophil kills. This is the oxygen-dependent MPO system, and it is absolutely lethal. First, an enzyme called NADPH oxidase creates a superoxide radical. Then, another enzyme, SOD, converts that into hydrogen peroxide. And finally, the star of the show, myeloperoxide, or MPO, converts that hydrogen peroxide into hypochlorite, which is literally household bleach. The body bleaches the terrorists to death. It's incredible. So throughout this whole battle, there have been generals and communication signals coordinating every single move. These are the chemical mediators. Let's head over to the Command and Control Center and see how this all comes together. This right here, this table, is your ultimate high-yield summary chart. You have to know this. From arachidonic acid, just lock in that prostaglandin E2 mediates pain and fever, while leukotriene B4 is a major chemotactic agent for neutrophils. Histamine, from mast cells, that's all about that initial vasodilation and permeability. And for complement, just remember C3b for opsonization, C5a for chemotactis, and the MAC complex for directly killing microbes. Master this table. It's pure gold. So the neutrophils did their job, but they have a really short lifespan. After about 24 hours, they're basically gone. So on day 2 or 3, a new player arrives on the battlefield to manage the cleanup and decide what happens next. And that player is the macrophage. I want you to think of the macrophage as the battlefield manager. It arrives, assesses the situation, and then dictates one of 4 possible outcomes. If the threat is gone, it releases anti-inflammatory signals like IL-10 for resolution and healing. If the fight's still raging, it uses IL-8 to call in more neutrophils. If the enemy can't be cleared, it walls it off in an abscess. And if the threat is just too much for the innate army, it presents antigen and calls in the adaptive immune system's special forces, which begins that transition to chronic inflammation. And that, everyone, is the entire arc of acute inflammation. It's a beautifully orchestrated, incredibly rapid, and powerful response.